So when we talk about cervical epidurals, I use, like I said, basically a complete catheter-based technique. So cervical spine, you can see the entry points are pretty small, okay? And they're also very flat, okay? So if you're coming in, 5'6", 6'7", they're gonna be, or 7'1", they're gonna be pretty flat angles, okay? I go down to T2-3 or T1-2, pretty much T2-3 almost exclusively, because, let's see where we are here, 7. Now, it's not represented very well on this, and we'll look at it on here, is you can get a nice big open space at T2-3, okay, most times. And so then also the other thing is your angle, you're coming in at a shallow angle, okay? So when you get into getting loss of resistance, a shallow angle is gonna help you from potentially stay out of the dura. Because when you're dead straight and you get loss of resistance, you can chunk into it, right? If you're like this and you chunk into it with these needles that I'll show you, you can likely deflect off of it. So you're not cutting into it, okay? So using a TUI needle, I don't recommend because it's got a sharp cutting edge. So some of these needles will show you they got a blunt edge. The introducer tip comes out a little bit further, so you can kind of push away the dura a little bit. So you can go right-sided, left-sided. The catheter, basically, if you're going to do them, you want it to kind of get, again, to the ventral-lateral space. You don't really have to get out the foramen with the catheter. I mean, you can, but you don't really have to. As long as you're ventral and a little lateral, it's going to get out there. Okay, so then we'll show you some of that stuff. The biggest thing, though, in my opinion, is the needle placement. That's paramount, because if your needle goes somewhere it's not supposed to, there's no, you're going to mess it up, and the patient potentially get harmed, especially in the cervical space. So that's why the X-ray exists. That's why these needles exist. We'll take a bunch of pictures, laterals, AP, and I'll show you things you need to look for, and to keep you safe and keep the patient safe. All right? Any questions at this point? All right.
Would you do the same thing, like if a surgeon was thinking about operating at a certain level and asked you for a cervical transplant?
So yeah, I do. I mean, I know I'm able to do it. Right now, you can do, I don't know, I'm sure, does anybody do cervical transfemoral? You could do it with, blunt needles, which is a little bit like a discogram. So I don't know if anybody's done cervical discograms. I used to do them. But those are only good if a person asks you to do them. They don't really get much yield out of it. But you can do it with a blunt needle where you just kind of slip in and get a selective nerve root block. Every now and then, if I have trouble getting in here, I'll take a blunt needle and kind of flip it into the foramen posteriorly, because if you come right on the facet line, you just drop it right in there with a blunt needle. Now you're posterior, but you're going to get a selective block. At least you'll get a selective root.
So you would still do a selective nerve root block with the catheter?
Yeah, yeah, absolutely.
Would you try to get out of the foramen?
You can, yeah, absolutely.
Is that what you would try to do?
That's what I would try and do, yeah. But if you're doing, a site-specific epidural, you can get to the foramen, and it doesn't have to be flipped out of the foramen. It could be on that level, lateral, you're gonna see the root spread. So, but sometimes people try to get out the foramen, and it's pretty hard to do.